Hi, it's Betsy Nicoletti, and I am once again recording a short video about when to bill a preventive or a wellness visit and a problem visit at the same encounter. And some of you may have watched older versions of it. I hope this is a new and improved version. I sound like I'm selling soap powder, right? So there are three key points that I want us to remember. CPC has been consistent about their guidance since May of 2002. When I audit these notes, if I'm going to add a problem-oriented visit to either a CPT preventive service or a Medicare wellness visit, I only do it if I only add the problem-oriented visit if the history of the present illness describes some symptoms of an acute problem or the status of chronic conditions. And I know that history is not a key component in selecting the level of service anymore, but in my opinion, I always want to tell you when it's a CPT citation and when I've gone out to my opinion. In my opinion, we're only going to add that problem-oriented visit when I have something described in the history of the present illness. And renewing prescription medications alone doesn't get you a separate visit. Frequently, the patient comes in for their wellness or their preventive visit, and while they're there, the primary care practitioner renews their prescription. Might as well do it now and not deal with a portal message in a week or a month. So we know what the CPT preventive medicine services are. They're divided by whether the patient is new or established and the age of the patient. They include this age and gender appropriate history and exam, which CPT doesn't define. They do say it's not synonymous with what the 95 and 97 comprehensive history and exam are. It includes counseling, anticipatory guidance, and risk factor reduction, which again are appropriate to that patient's age and gender. Then immunizations, if you buy them, you can charge for the serum itself, but you always charge for the administration. And then ordering screening labs or diagnostic procedures. And not all patients need those at all ages. And then we've got the Medicare wellness visits. Now, the CPT preventive medicine services are considered by Medicare to be routine, and if you bill them, they're patient due to a patient who has original Medicare. There are some Medicare Advantage plans that cover them, of course, making it just a little more complicated for our primary care clinicians. Since they are considered routine, that means they are never covered and you're not required to get an advanced beneficiary notice. But Medicare put out a recent MedLearn Matters article, I think it was November of 2023, somewhere around there, where they recommended getting an ABN, even though it's not required for routine services. So they must get complaints from patients who say, I went in and I got charged for my preventive medicine service, and I thought I was getting my wellness visit. And then we have the three wellness visits, the Welcome to Medicare. That one's not considered a wellness visit. The Welcome to Medicare visit and the two wellness visits, the initial and the subsequent. So what does CPT say? CPT says that if an abnormality is encountered or a pre-existing problem is addressed, they still use the words, and this requires additional work for the key components, then add an office visit and put a modifier on. This quote goes on to say, if an insignificant or trivial problem is addressed, don't bill us a separate E&M. In February of 2021, CPT was asked if there was going to be changes in this reporting, and they said no. The changes to the E&M services that we got in 2021 didn't affect the preventive medicine services. But then they were also asked in that and answered in that same journal article about using time. And they said, if time is used for selecting a level of the office visit, the problem-oriented office visit that is being billed in addition to the preventive service, the time spent on the preventive service cannot be counted toward the time of the work of the problem assessment because because time spent performing a service cannot be counted twice. It's a long-standing CPT rule. We don't double count time. The code for the problem assessment portion of the encounter will likely be selected based on MDM. So they say, yes, you can use either time or medical decision-making to select a problem-oriented visit at the same encounter as a preventive medicine service, but we think it's more likely that you'll use medical decision-making. And if you use time, don't double count any time. And I can imagine in the exam room, it's hard to say, oh, is that 18 minutes of the problem visit or was it 22? We don't have a stopwatch. So here are some examples from CPT 2002. A patient comes in for a GYN exam and a breast lump is found. So the physician identifies this on the physical exam. CPT says additional work is done to support the key components of the visit. And they say that the breast lump should be reported in addition to, as a diagnosis, and an additional visit reported. And then the same example of a well child visit with a kid with a child with otitis media was in the 2002 CPT assistant and in the March 2023 explanation of when to use modifier 25. And it says the physician finds the patient has a otitis on exam, and they elicit additional information about fever, difficulty sleeping, rhinorrhea. The preventive medicine service is done and documented. And then CPT says, as part of the medical decision-making process, there was a discussion regarding the appropriate use of antibiotics, why labs aren't indicated, and when you should call the office again or go to the ED. And again, they say, bill an extra E&M service. In neither of these examples or in the next one, do they select the level of service for us. So please just tell me what level you're assessing here, but the CPT assistant doesn't do that. And this was a family medicine, internal medicine example from 2002. A patient who presents with 3 chronic conditions, hypertension, diabetes, and chronic stable angina, all on medication. CPT says a comprehensive history and exam are done, and then a specific history is taken and the examination is given that includes vitals, chest, heart, and check for edema. Now, I think that would have been done on the preventive medicine service, but that's what CPT says. And they said an ICD-10 diagnosis for the pre-existing problems addressed would be reported, and they should be associated with the problem-oriented E&M visit that is reported. So we bill the preventive service with the examination code, and we bill the office visit with these other 3 condition codes. Now, what can we learn from this 2002 example? CPT says a specific history is documented. Good, I'm going with that. CPT says we need a specific history, or they describe that, I'm happy. They say there's a further exam done, which was probably already documented. The patient has 3 stable chronic conditions. The CPT book example doesn't describe treatment changes or medication changes. So when I look at that, CPT doesn't seem to be requiring the patient is unstable or to have a change in the treatment plan in order to add a problem-oriented visit. And I do hear from medical professionals who say, well, what was the extra work that this practitioner had to do? Everything was the same. They were just reviewing those conditions and renewing the medication just. I think most of our clinicians would say it's not just when that's happening at the time of a problem of a preventive service. And we have this CPT support for that. The unstable isn't required and a change to treatment plan isn't required. So this has always been my opinion, and I'm going to support it with this CPT example. So when I audit these encounters, I got to have an HPI. It could be a description of an acute new problem or the status of chronic problems, and the HPI is documented at this visit. It's not just everything from before. We don't need a book, but don't be this person. hypertension stable, diabetes says no symptoms, cholesterol not sticking to diet. We wanted something a little more than that. So we're going to bill a preventive service only. So remember, when we're selecting our level of problem-oriented visit, we're going to use, if we're not using time, we're going to use the 3 elements of medical decision-making. My examples here are heavy on the number and complexity of problems, but with that, we would need data or risk from additional diagnostic testing or treatment. I'm not suggesting we only need one of the 3 elements to select an E&M service. Please underline that in your brain. So if the patient is in good health, or a patient has chronic problems that were addressed recently, a patient who really just comes in for their preventive service. Maybe the chronic illness is listed with just a few words. This is a patient with a history of hypertension, stable angina, and hyperlipidemia who presents today for their preventive service. Doesn't describe the status of them. And, maybe there's no change in treatment. Conditions are listed, but not evaluated or managed. And even if we refill existing prescriptions, that doesn't give us an office visit. Now, I'm going to talk about level 2 and level 5 visits in a minute. A level 3 visit would be for a patient who at their preventive or wellness visit has an acute uncomplicated illness or a patient with one active stable problem. And they're described in the HPI. If it's a acute problem, we've got the symptoms related to it. If it's a chronic problem, the status of it is described. Let's have a sentence or 2 at minimum, right? And then when we get to the assessment in the plan, we've got this one stable problem. Maybe there's management of that problem with refilling the prescriptions, or if it was the acute problem, treatment for the acute problem. When we get to the level 4, it could be an undiagnosed patient, a new problem with uncertain prognosis and 3 data points, or a patient with a significant exacerbation of one or more chronic conditions, and these are described in the history of the present illness. Or it could be a patient who's got 3 or 4 or 5 or so many chronic conditions. None of them are particularly in terrible control. Some of them could be better, just the way patients are. But they're described in the HPI. And when we get to the assessment in the plan, we have the treatment plan for one or more of those conditions. And often it could be prescription drug management as well there. And we're going to bill we're going to bill the office visit only for a patient who is so sick or has so many problems that you don't have time to do the preventive service. So maybe you're literally calling an ambulance, or maybe you're saying, boy, seems like you have a lot of things you want to talk about today. Let's reschedule your preventive service, because we don't have time to do both. Now, CPT allows all levels of E&M services to be reported with a preventive medicine service. My opinion is that level 2 visits really can be described often as an insignificant or trivial problem. And CPT has already told me not to add a problem-oriented visit for an insignificant or trivial problem. So I rarely say, why don't we just add a level 2 visit to our preventive medicine or wellness visit? And for a level 5 visit, you'd be spending either 40 minutes for an established patient on the problem-oriented portion, plus the preventive medicine service. Do your primary care doctors and nurse practitioners and PAs really have that much time for a visit scheduled? We'd be looking at an hour and 20 minutes or an hour and 10 minutes, whatever. Or the patient would be so sick. So in my opinion, I think it's unlikely. But CPT allows all levels of evaluation and management services to be reported with a preventive service, and Medicare doesn't differentiate either. They say you can bill a problem-oriented visit along with the welcome to Medicare or the wellness visits. So thanks for watching it. It's a rerun. There's a lot more information over on Coding Intel, both on YouTube and on Coding Intel. We have videos, and there are free articles for non-members. Thanks very much for watching.